Welcome to our newest episode of the Lebanese Physicians Podcast. And this is episode number 80 and being recorded before the end of the year in Beirut, Lebanon at Bar Tartine and at Bliss Street. And today we will be discussing neonatal care and resources in Lebanon with Dr. Fawzi Maalouf. Dr. Maalouf is a Assistant Professor of Neonatology and Neonatal Intensive Care at the American University of Beirut. He did his medical school at AUB, went to the US, where he did his pediatrics residency at the University of Arizona in Tucson, Arizona, and then did his NICU fellowship at Vanderbilt University, and moved back to Lebanon immediately afterwards to help out the country. Welcome, Dr. Maalouf, to the podcast.
Thank you. Thanks, Khalil, for having me. It's a pleasure.
Dr. Maalouf, first, before we start diving into neonatal intensive care, can you tell me what the field of neonatology is, who does it take care of, and who needs neonatal intensive care from the neonates?
So neonatology as a specialty, it's a medicine that takes care of babies in the first 28 days of life, which is a neonate or a newborn. We usually take care of all babies. However, babies that will require intensive care are those who are either premature, meaning that they are born before 37 weeks of life or before the 9th month of pregnancy, or babies who have some other problems that are either diagnosed before they are born or as a congenital malformation, or babies that have problems adjusting to postnatal life. So after they're born, they have difficulty either breathing or have some heart diseases. So this is the specialty in general. We cater to a lot of patients. We see babies who are either extremely premature, so these are babies that are less than 28 weeks of gestation, and this is a group of very fragile patients that we call extremely premature. We have babies who are very premature, who are between 28 and 32 weeks of gestation. There's a group of babies who are late preterm, so these are between 34 and 37 weeks of gestation, and then the rest are the term babies. So I work in a tertiary center, which is the American University of Beirut. We have all pediatric subspecialties available. We cater to most of the country, and we have surgical care for all these babies.
Thank you, Fawzi. That was a good overview of neonatology and neonatal intensive care. And actually, I learned some from you from this answer. So I'm going to discuss with you neonatal care worldwide, because we hear, when you start reading, I'm in medicine, but obviously I'm not in pediatrics, so I don't read a lot about pediatrics. But when you read the news or you read some papers, you see that survival of neonates is getting better, like premature babies who are even born more and more prematurely are able to survive and maybe lead a normal life. Can you tell us what are the advancements in neonatology worldwide and how these are affecting survival of neonates?
Neonatology as a field is a relatively new medicine. So the development of neonatal intensive care has been mostly in the 1950s and 1960s. That's why compared to other medicines, it is one of the more recent ones. We know historically that the younger or the earlier a baby is born, the more likely that they will not survive. However, in the last, I would say 30 to 40 years, we've had a great improvement in survival. We have babies who historically would not survive hours or days outside the womb that are actually being discharged home and have an almost normal quality of life. So babies who are born at the limits of prematurity or limits of viability are babies who are usually between 23 and 24 weeks historically. So this is, for some people, they call it, they use the months. So this is about 5 to 6 months of pregnancy. Now we have babies who are even earlier in the world, so 22 weeks or 23 weeks, which is the edge of viability. This is physiologically the limit of a human being able to survive, mostly depending on how mature their lungs are when they're born. So in many advanced centers across the world, from the United States, Europe, and Japan, we have seen more and more publications of these babies surviving. Now, the challenge faced previously was a lot of places would not offer care to those babies who were at the limits of viability, knowing that their chances of survival are not that great. And now there's more and more openness to that, and more care is offered to these babies who are at the limits. So the bread and butter of neonatology across the world is babies who are born after 28 weeks of gestation. However, we are seeing more and more daring treatments for those babies who are born earlier than that.
Excellent. Yeah, thanks for all the work you do. And now I'm going to ask you about the care at AUB. I remember when I was a medical student, my only memory of neonatology was like going in very early and counting calories. And I didn't have very good memories of these days, but how's neonatal care at AUB now, and what are the advancements, and do medical students still count calories at this point? And then after you tell me about neonatal care at AUB, has it been affected by the crisis? And if it has, is it back to normal now?
I share with you the same memories. When I was a student at AUB, I also used to go in at 6 in the morning and count calories. No one wants to do that. Thankfully, there are electronic health record and systems that do that for us now. But we also want to teach students, residents, fellows these, because you never know when and where you will end up being. You might be in a place where they don't have the luxury of having electronic health systems that can do that for you. So it's interesting to understand the physiology and the medicine behind what we do. Neonatology is a very critical field. It all depends on the small and minute details. The babies we take care of are tiny. Any change in the doses that we give, the calories that we give, the volumes of the medications that we give, all are factored in at the end of the day. At AUB, so the level of care that we offer is, I would say, top tier care in Lebanon. We take care of all kinds of babies who are extremely premature. We're talking about babies who are born as young as 23 weeks, or babies with major congenital anomalies, such as congenital heart disease. You recently mentioned the conjoined twins that we did at AUB, so that also is something that we've done recently. The number of patients that we typically used to see before the financial crisis was about 15 to 18 babies at one time. Our unit can see babies up to 20, 23, 24 babies at a time. However, more recently, we're mostly seeing between 5 to 10 babies in the unit at one time. And that has to do with decreased in insurance coverage, decreased deliveries throughout the country, especially at AUB, and the financial limitations to be able to afford this level of care. We've gone to different units across the country, and we see this trend too. And I'm talking about private hospitals. There has been a decrease or shift toward a decreased number of patients throughout. I don't have an explanation for that, because also when you're sitting with friends and talking about the deliveries, people say, our deliveries are still the same. Some will tell you, no, the deliveries are dropped. Now, another problem with when we're talking about numbers and the crisis is we had a shortage of medication at some point. Also, the financial crisis affected a lot of patients who had good insurances and lost their insurance, or had subsidized insurance through the Ministry of Health that also lost that. So these patients don't end up coming to our hospital. They might be going other places too.
So my next question for you is, we talk about NICU care at AUB. How is NICU care in the rest of the Beirut area? I mean, there's a number of big hospitals in Beirut, but then there's also a number of smaller hospitals in the Beirut area. So how is NICU care in these hospitals too? And do they offer the same services that AUB is offering at this point?
So one thing I can guarantee you is, in Beirut, there's no shortage of hospitals. You have many hospitals within one block and walking distance. Some see it as a positive. I probably see it more as a negative. Sometimes competition is not the best thing to have, especially when you're dealing with critical situations. You want more patients to be in one place, taken care by the same team throughout. So I don't usually go to other places. I've visited some places. We have a project we probably will talk about later on, but we've visited some of the other NICUs that are associated with academic centers. So those with medical schools tend to have a decent quality of care. Places don't usually share their numbers, but just talking to our colleagues, we see that they're doing a good job. But the only limitation is they offer care to older babies than we do. We tend to see the younger, more premature babies. I think that's because this is how our practice has been throughout. Now, this is only in private hospitals. We know that a big chunk of patients in Lebanon do not have good insurance, or do not have any insurance at all, and they're dependent on governmental services. So we've been to different governmental hospitals, and the main limitation to care there is the financial aspect of things. There's a lack of equipment, lack of physicians, lack of training that's not available actually, and this might affect the care that we see in other places. We, as a tertiary center, we also get referrals from different places. And sometimes we get babies who are coming from different hospitals who are late in the stage of their illness. So these are babies that, if they were picked up earlier, would have had better outcomes. Recently, we've seen a bunch of patients who had one of the complications of prematurity is retinopathy of prematurity. So this is when the vessels in the eye don't develop properly and can lead to blindness. And this is one of the more common causes of blindness in babies. If detected earlier, we have services and treatments that we can offer to these babies. So recently, we've seen a lot of babies, infants who presented to some of our colleagues who had advanced disease, and mostly the reason was because they were not screened adequately or in time. And I think that has to do with the lack of subspecialists in the peripheral areas and even in Beirut.
Yeah, which brings me to my next question, which is how's NICU care in the rest of the country? Because we know that in Beirut there's a lot of hospitals, but how's NICU care, let's say, in the north, in the south, in the Bekaa Valley, and other areas of the country at this time? Is it as adequate as it is in Beirut?
To answer this question, I will refer to a certain project that we've been, so our group at UB has been working with and in collaboration with United Nations, UNICEF. So this is a project that enabled us to go to different governmental hospitals in the peripheries in Lebanon. We've had hospitals in Akkar, Tripoli, the Bekaa area, so different provinces in the country. And we were able to actually visit these hospitals, talk to the physicians, talk to the nurses, look at the babies in the NICUs. And we saw a really, the situation is really bad. And this is reflective of what the country is going through recently. We have basic resources that are not available. As I was saying earlier, one of the mainstays of neonatal care now is through non-invasive ventilation, which is CPAP. And CPAP in most of these hospitals is not available, and it hasn't been available for years. So a baby is either on no support at all or intubated on a ventilator. And most babies in the NICU are usually on non-invasive support. So we try to avoid intubation. There is a lack of medications, lack of testing. So we've been to hospitals where they don't even have the blood culture bottles to check if a baby has an infection. So they would just treat the baby anyways and expose them to antibiotics. We have places that they don't have the blood gas machine. So if a baby is on a ventilator, the parents have to go to a private hospital across the city, buy the syringes, come to the hospital, get the lab, send it back to the other hospital, and wait for the results, which delays care. And sometimes people don't have the financial means to do so, and physicians are just going by how the patient looks. So it's kind of rudimentary neonatology compared to what we've seen in the last 20 years. And that will eventually lead to worse outcomes. And we will see these babies years to come who are affected by this.
My next question is talking about that. So does the Ministry of Public Health keep records of outcomes in the different hospitals that patients or the public can access? Or there's no such records to see, for example, which hospital has better outcomes and which hospital has worse outcomes?
Collecting data in general in Lebanon is not the forte of the Ministry of Health. There has been for example, a registry for birth defects that was developed years back, and that should be accessible because it's public. So you can tell how many birth defects are there in a year. When it comes to actual mortality and morbidity, there's no way of knowing that officially. Everything that we look at is either non-official reports or surveys done by different institutions or organizations. But the Ministry of Health currently does not have a mortality reporting or morbidity reporting. And this is a major flaw in our system, because if you don't have your numbers, you don't know where to target your interventions and follow up on what you're doing. We are in a process of developing such a surveillance system. However, it takes a lot of resources, as you probably can see. We're in a country that is facing so many problems. Even if you develop a resource or a way of surveillance, you need to continue that in the future. And this has to be planned by the Ministry of Health.
Yeah, I agree. And which brings me to the next question, which is what is the benefit of perinatal regionalization? And one is, let's define it. Two, and as I've heard from you and from others, it's lacking in Lebanon. So what's the benefit of perinatal regionalization? And first, also, can you define what that means in this case?
Perinatal regionalization, so it's two words. Perinatal is anything that has to do with the care of the pregnant woman before delivery, during delivery, and after delivery, which also includes taking care of the baby, the neonate or newborn. And this care, which is called perinatal care, once you regionalize it, so you set different regions for different kinds of care, that's what most healthcare systems would end up having better outcomes. For example, I would first define level of care of a newborn, neonatal intensive care. There are 4 levels of care. So a level 1 neonatal intensive care unit or level 1 newborn care would be what you would see in a regular newborn. So a mother comes and delivers, baby is born, doing fine, just needs support for the next few hours, make sure breastfeeding is doing fine, and then you would send them home. Level 2, and this is mostly for babies who are born term or late preterm, so end of the 8th month or the whole 9 months of pregnancy. Level 2 care would be babies who are either born late preterm and have some difficulty, for example, with breathing. You would support them with non-invasive ventilation, or babies who are born prior to that, so more preterm babies. And the goal of the level of care there is to stabilize the baby, make sure that they're able to be transferred somewhere else, which has a higher level of care. And that's where the regionalization makes a difference, because once you're in a lower level hospital, you need to have some sort of a regionalized system to know where to send your patients. A level 3 and level 4 are very similar to each other. This is a major center that is a referral center to the area. They take care of any newborn baby, be it term, extreme preterm, babies who require mechanical ventilation. And the difference between level 3 and level 4 is in level 4 centers, you will need the availability of pediatric subspecialties to make sure that they are doing the proper consultations, and the presence of surgical specialties, so that if a baby requires any sort of intervention, surgery, then they can do that over there. These are the levels of care. So perinatal regionalization is more of a system where you can detect any high-risk pregnancy, which would result in a high-risk newborn, and you will know what services are needed in a different area. For example, let's say we're talking about the region of Beirut. So for Beirut, you would need, let's say, because it's one of the more populated areas in Lebanon, so you would require many places that are level 1s where they can take these babies, because most babies, as I said before, 90% of them will not need any extra neonatal care. So you will have more birthing places, birthing centers that can accommodate regular deliveries. But for every certain number of basic centers, you will need a higher level of care to go to, because you don't want someone to deliver in Beirut and then you will have to send their child to the Bika. So it's because we not want families to be close to their newborns. So you would have less and less level 2s, and then 2 or 3 probably level 3/level 4 centers in Beirut, and this should be duplicated in different places in the country. I know it's not feasible to have higher level care in all of the country, but you will need some sort of a safety net in most of the provinces where you can stabilize patients and know where to send them. Now, a big barrier to that would be finances, of course. So a mother delivers in the Wika and they have limited resources, the baby is stabilized, but then you want to send them to a higher level place, probably in, let's say, Beirut, but the family cannot afford that. And the ministry, let's say the Ministry of Health is covering the hospitalization, but the Ministry of Health doesn't have a place to put that baby. So this is how the system fails. So everything should be set up front. And for this system to work, you need also a way to transfer patients. You need a good transport system that includes a transport nurse, transport physician, good ambulances to take care of these very, very fragile babies. And you also need a way to reverse transfer or back transfer babies after they are stabilized and they're sent to a higher acuity center. Once they're stabilized and they can be taken care of in other places, more primary cases, you can send them back. So yes, as I said, finances are a big issue. The other issue is also awareness and medical literacy. A lot of people in the country don't know that. I mean, they don't know. They think that all babies are the same, premature, whether they're premature or not. And if they're premature, that all premature babies are the same. And that's not the case. Babies who are born more and more premature will require more care and more advanced services, and they need to know this upfront. So I talked mostly on neonatal care, but when we're talking about perinatal, let's say you detect a mother who is at a high risk of delivering extremely premature. Instead of delivering a baby somewhere else and sending the baby, it's probably safer to send the mother, and we call this an in utero transfer. So the baby is actually being transferred in the mother before the baby is delivered, so that the mother can get adequate care and the baby can get adequate care in a highly specialized center.
Yeah, so basically, I understand from you actually, I would say that basically similar to, let's say, a STEMI or something like that, right? Where you have a center of excellence for heart attacks, and then you send the patient directly to that center of excellence if they have a ST elevation or a severe heart attack, and similar to a stroke. And probably it's the same for perinatal care, because if you send the patient in earlier for assessment, then probably the outcomes are better. I don't know the data, but probably I assume that the outcomes will be better if that happens. So saying that, because we were talking about payments and insurance, and I know when I used to work here, I remember that I was surprised initially when I learned that the ambulances are not as equipped as they are in the US. Like you get a regular ambulance, it just transports the patient, maybe has some oxygen in it, but doesn't have much. And if you want more than that, you have to pay money for that, and that'd be hard for transfers. So saying that, so what's the insurance coverage for most people in Lebanon? How is it? How are they covered? And also, how does it compare to Syrian refugees? Because there's a lot of talk of, oh my God, like Syrian refugees are better covered than Lebanese people. And I don't know if that's true or not, but what's the insurance coverage and how does it compare to Syrian refugees?
So I won't open that kind of worms about about the differences between Lebanese and Syrians, but yes, transfers are a problem in Lebanon. We don't have the equipment. We're mostly dependent on non-governmental organizations, mostly the Red Cross for transfers. And the Red Cross just comes with a driver and an ambulance. You don't have physicians there. You don't have nurses there. And equipment is lacking in the ambulance. So yes, insurances don't cover transport. So as you said, people end up paying out of pocket for transports. And if you get lucky and have a physician with you in the transport, then that's gonna cost you more. Looking at the population, I don't have the exact numbers, but most people in Lebanon don't have private insurance. And you know all the problems with having your national insurance and national services, Daman. The problem is if you don't have insurance, they probably won't have good care, and that will be reflected in the outcomes too. So if you don't have the insurance, then it will be a problem going from one hospital to another. One thing that we see in Lebanon is if you need to be transferred from one hospital to another, before doing so, you need an approval from the receiving hospital. And if you don't have the ways or the means to pay that hospital, then they will not accept the patient. And this patient will end up staying in a hospital waiting for some sort of help. Now, to help with this, there are different organizations and funds throughout the country that might help with that. But still, this is just putting a band-aid to the main problem, which is the financial situation of the country. So having a fund helping here and there does not solve the main issue, and does not target all people that are available in Lebanon. Now, there are talks, as you briefly introduced, between, we have the big problem, which is the Syrian refugees in Lebanon. And there are many UN organizations, mostly UNHCR, that is helping with healthcare of this population, which is growing slowly. And so you end up having Syrians who are able, through international funding, to get relatively good care in many hospitals, whereas a Lebanese citizen who does not have insurance is not able to get that care because of their financial burdens. And that's, I think, where the anger comes from. Why are these people getting better care than I am? But I think the main responsibility goes to the Ministry of Health, because every Lebanese citizen should have some sort of funding from their own country. The care does not change between Lebanese and Syrians. And in medicine, we do not see color, we do not see race, we don't see nationality or ethnicity. So if a patient ends up in a hospital, and you have to do whatever you have to do to save a life, but then when things cool down and you're starting to think about what different practices, what different medications I can offer, finances can become an issue. And I think there's better kind of coverage for Syrian refugees nowadays compared to just the Lebanese citizens, as long as they don't have private insurance.
Right, and to put it into perspective, I think private insurance in Lebanon costs a lot of money right now. Like if you want, let's say, primary, like first class, there's first class, second class, whatever private insurance, you can pay, depending on your age, you can pay anywhere between $3,000 to $13,000 a year or something like that for this insurance, and that's out of range for a lot of people in the country. And but the other thing I would say too is when I've talked to a lot of NGOs such as the AFD or the International Rescue Committee, they say that they're helping more and more actually Lebanese citizens these days compared to what they were in the past, just because a lot of them need help at this point. But now going into this, so what is the initiative with the UNICEF, and what are you guys at AUB doing with the UNICEF to try to improve the situation currently in the country for neonatal care?
This is a project that started, I think, a year or two ago. It was started by our head of division, Dr. Yunus, and a team of people that includes physicians from different hospitals in Lebanon or different universities in Lebanon. It includes nurse educators, and pharmacy, nutrition, respiratory therapists. So this project was initiated to get an idea of what is the neonatal care like in Lebanon, mostly in governmental hospitals or public hospitals. And we chose 4 different hospitals through different parts of the country that were interested in being approached. We've had several visits to each of the hospitals. We went in, looked at all the equipment, talked to the physicians, talked to the nurses, and we saw that the same theme comes over and over: financial burden. People are not getting paid as much as they could. I mean, one example, I was talking to one of the nurses and in one of the remote areas, and she was saying that her salary was $80 per month. This is a nurse who's spending about 14 shifts every month. Every shift is about 12 hours taking care of very sick newborns. And all they're compensated with is $80. And for them to go and get paid, the cashiers in their hospital doesn't have $80, so they have to get the exact change. So the hospital will give them 100 and they need to give them 20 back to get paid. And if you're not getting paid enough, you're not able to provide for your family, I think your will to help others will be less and less. So we were looking at these hospitals, and we noticed one recurring theme was the financial burdens. Another theme was the lack of equipment. The others were lack of testing and lack of labs that are should be available in governmental hospitals, which has led to many hospitals, they refuse taking care of babies born less than 35 weeks of gestation. So all these supposedly level 2 or level 3 NICUs are automatically now level 1 NICUs, such as a normal nursery. And the question has always arisen. So you go, and so a woman goes and she delivers at 28 weeks, and the hospital says, no, I can't take care of this baby. We always ask the same question. So where does that baby go? And we never get that answer, which probably means that either people are taking those babies to die at home, or they're finding some other way to go to another hospital. So to help with that, with this initiative, we have compiled a neonatal care course, which is mostly driven by neonatal nursing, and some of the physicians give some of the course. We have asked nurses from these participating hospitals to come to AUB. They attend the course. It's a 2-day course, and then they spend 1 or 2 weeks in the NICU at AUB to see how things are done at our place. And we're hoping that once they go back to their referring institutions, that they should be able to offer this practice over there. When it comes to physicians, it's probably a little trickier. We can't just bring physicians and say we want to teach you neonatology all over again. So it's a little tricky there. But we're making some efforts into that. And our team also has been to these centers after these lectures, and we're doing some spot checks to make sure that things are doing fine. Now, with the help of the UN, UNICEF, we're trying to also acquire equipment to these hospitals, and apparently they have a lot of equipment that's just ready to be there. We just need to ask for it. So this is something that's helpful. Hopefully, moving on, we're trying to include more and more governmental hospitals to include in the future. Now, a problem that I noticed when we were doing this project is we have many provinces in Lebanon where they don't have governmental hospitals with neonatal care in them. For example, two main areas in Lebanon are Kisrwan and Meten, which host a significant number of population, of the Lebanese population. And these two places don't have any neonatal care, governmental neonatal care in this area. So people end up going to privately owned centers.
Let's say you have a level 2, level 3 patient who comes to a hospital who cannot take care of them. At this point, I know the initiative hopefully will help with that. And they need to be transferred, and you get a call at AUB. We need to transfer this level 3 patient over to AUB. How does the process take place? And are you able to transfer the patient even if they don't have, let's say, coverage? And if you want, you don't have to answer the question.
I can tell you as much as I can tell you. So medically, and I teach that to my trainees, I never refuse any medical transfer. So from a medical standpoint, any patient that wants to come to our center, medically, I'm in a referral center, so I have to accept every patient, whatever it is. Is it a patient that will come and die in my hospital? I don't mind that. Problem with usually is administrative, because the administration eventually can block a transfer based on finances. So if someone is not financially clear, then that might be a problem. We try to mitigate that we have something called the Neonate Fund, which is a fund that helps babies that need admission to the Neonatal Intensive Care Unit. Now, this fund has its own limitations, especially with all the crises that happen, but we try to help as many patients as we can. But medically, we never refuse a patient. Hopefully that could answer the question.
Yeah, it did. And it seems that keeping this neonate fund, I guess, funded in a good way probably will be helpful to get all the babies that need to be transferred over effectively using that fund. So basically, I think it was a good talk. I just want to ask you any parting points that you have, and what do you think the future prospects are for NICU care in Lebanon?
Well, thanks for having me, Khalil. I think we need more and more education and awareness in Lebanon. Many of these problems that we see can be solved by just having the proper knowledge. For example, a woman who is in a high-risk pregnancy can actually go to a place where she knows that her baby will be taken care of. Ask questions to your insurance companies. We have a lot of insurance companies that don't tell you that they might not cover a baby. You're pregnant, you deliver, and they tell you, oh no, we don't cover a baby if they go to the NICU. And so these are all these fine prints that some people, I think, need to ask about. If you have a way of helping patients, either by donating or supporting in any way possible, I think we are going through a point where we need all the help that we can get. And in general, we're really doing this as a specialty. We're doing this to enable all these babies who were not supposed to be with us. We're trying to offer them a decent life, and we really work hard. We are very meticulous. As you said, we are counting calories to make things better. I think we just deserve better as a population. Our kids and babies, they deserve much better than what we're faced with.
If people want to donate to the Neonatal Fund, how do they do that?
They're on social media. There's a number there that they can call, and I think if you just Google Neonate Fund, you'll find it.
Yeah, we will place that number once we publish the podcast. So thank you, Fawzi, for discussing neonatal care in Lebanon at AUB in Beirut and the future prospects with us today.
Thank you, Khalil. It was a pleasure.